I figured you heard your file's too big.
Yeah.
All right.
And it's, yeah, the first one there. Thank you. Great. Oh, great. Actually, can I put it on, oh, it is on presentation mode. Cool.
Yeah. You have to adjust this over here, right? You can do either go by letter or actually bring the line down right there.
Okay, that's fine the way it is.
And shove it across that side too.
If it shows up,
Yeah, you can go through the side again.
like if there's more text below, it'll let me scroll down, I guess. This one doesn't have more text, but I guess
okay,
another
yeah.
one so it would probably. It doesn't really matter, I guess. But.
I'll just make sure that.
There we go. Yeah. Oh, I guess it's showing all of it.
Well, you can also, if you need to, just
I see. Yeah, that'll work. Okay. That's great. Thank you so much.
Yeah. Testing 1 2 1 2.
Good morning, everybody. Is this on? Hi, PJ. We okay? Good morning, everyone. Welcome to Grand Rounds. Next week, our Grand Rounds speaker is going to be Dr. Adam Brickman, who's an associate professor of neuropsychology, appointed in psychiatry, neurology, the Sergeyevsky Center, works in aging, and I don't have a title for it, but I'm sure it's something on aging brain or dementia. But Adam works with Brett Rutherford, Dev Devanand, a lot of people, and I haven't heard him speak before, so it'll be very interesting too, especially since I'm moving into an older age demographic. Have a few announcements to make, happily. Number of grants were received, the NOGAs, Notice of Grant Award. Frank Schneier got a 2-year R61 from the NIMH for GAZE Contingent Music Reward Therapy for Social Anxiety. Okay. Wonder if Richard Kogan is collaborating on that. Marissa Spann received a 3-year K23 from the NIH for a project on maternal immune activation, fetal infant neurobehavioral development. Did she work with you, Catherine? How did I guess? Brad Miller received a K08 award from the NIMH for a career development scientific program for mapping serotonergic activity during emotional behaviors in the healthy and stressed brain. Matthew Leibowitz received a K99 from the NIMH for a project understanding implications of genetic attributions for addiction. I didn't know about that. A K99, how many people know what a K99 is? That's a lot. It's like skipping a grade. You just go right to being an independent investigator from having been a trainee. So is Matt here? That's probably why I got the K99. He's so hardworking. Diana Martinez received a 4-year grant from DOD for a project on investigating NMDA antagonist ketamine for the treatment for tinnitus. Brett Rutherford received a R21 from the NIA for a project on sensation and psychiatry, linking age-related hearing loss to late life depression and cognitive decline. So I'm guessing that great paper you had with Katie and others in the AJP was like the background and rationale sections of the grant application. That's a good way to multitask and repurpose. And Melissa Arbuckle received the award, the Outstanding Educator Award from the Association for Academic Psychiatry for this year. And in line with that, one of our residents, PGY3, Rachel Fremont, who is a Levy Fellow, was selected by the NIMH to receive an Outstanding Resident Award. So the NIMH picks across the country some relatively small number, and we've had the amazing record of, I think, 12 of the last 13 years having somebody selected in that regard. So congratulations to them. Our speaker today is our own Jonathan Posner, and Jonathan didn't program himself to give Grand Rounds because he's the coordinator of the Grand Rounds. I sort of leaned on him just like he leans on me. But Jonathan hails from New Hampshire and received his undergraduate degree at Wesleyan University in Connecticut, his medical degree at SUNY Downstate, Brooklyn. He then proceeded to sort of experiment in other disciplines, first in medicine, then in diagnostic radiology for a year, 2 years, and then came to his senses and became a psychiatry resident here at Columbia. But in between, he did a fellowship to explore research, and it's not surprisingly, that was in the developmental biology division. So was that with Myron or Jay or Bill? Myron was the PI of the grant, and I worked with Brad Pearson. Okay, so he did a fellowship before beginning his postgraduate training in psychiatry, which he completed. Then he went to Oregon for a child fellowship and returned to Columbia for yet another postgraduate research fellowship. And clearly had established an area of interest in research and not surprisingly, applying neuroimaging techniques to the study of mental disorders with an emphasis on youth. What's particularly notable about his body of work is that it's very diverse in terms of the number of disorders that it's applied to, using cognitive neuroscience and functional magnetic resonance imaging to interrogate brain systems, but also that it's very collaborative. He really has a wide range of collaborations, which must mean that he's easy to work with, or good to work with. But just to give you an idea, he has an R01 with Joanne Steinglass on longitudinal assessment of neural circuits in adolescents with anorexia nervosa. He's working with Myrna Weissman on her classic 3-generation study of risk for depression. She's part of the ECHO project with Christiane Duarte, Ian Canino, Catherine Monk, studying breaking the cycle of intergenerational disadvantage, neurodevelopment among Puerto Rican children. And then what's probably his sort of stock and trade, another NIMH R01 on imaging stimulant effects on emotional lability in children with ADHD. The work has been reflected by prolific publication in scientific literature. He has 36 publications, 26 he's either first or senior author on. So he's really become quite accomplished in sort of hot technology in studying mental disorders in a variety of ways. And today he'll be talking about this to us and how it can facilitate treatment development. So please welcome Jonathan Posner.
Okay. So first, thank you, Jeff, for that introduction, and thank you, everyone, for coming out today on this beautiful summer day. So I'm going to talk today about, actually, sorry, let me just get this set up. Okay. Yeah, so I'm going to talk today about an area that my lab has been working on for some time, and that is trying to use neuroimaging to better understand how our treatments are effective. In other words, to try to identify the underlying biological mechanisms by which treatments exert their therapeutic effects. So I'm going to start with some background, and I'm going to talk about these concepts of rigor and reproducibility. And I realize that these words have become essentially buzzwords and unfortunately have lost most of their meaning as a result. But I think particularly in this area of research, treatment mechanisms, treatment studies, their importance really can't be overstated. And then I'm also going to talk a bit about data-driven approaches versus hypothesis testing. Then I'm going to review some of the recent changes that have taken place at NIMH in its approach to clinical research. In the second half of the talk, I'm going to focus on 2 studies that we recently completed looking at antidepressant mechanisms. And these are studies that we completed in collaboration with David Hellerstein and the folks in the Depression Evaluation Service. And then in the last part of the talk, I'm going to talk about an area where we're really trying to push the envelope a little bit and move beyond sort of the limitations of MRI scanning, where we can have MRI substrates or neural circuits that are the mechanisms driving treatment response, and drill down deeper and actually look at cellular targets. And this is very much a work in progress, and I'm going to talk about the psychostimulant study that we're doing towards that end. Okay, so rigor and reproducibility. You know, when we think about treatment studies, in particular studies looking at treatment mechanisms, I don't think anyone would argue with the point that the most rigorous methodology that we have is the randomized clinical trial, where you have both randomization and placebo control. And yet when you look at imaging studies that have looked at mechanisms, the vast majority are still using either cross-sectional designs or single-arm designs. And specifically, when you look at antidepressant studies, this was actually quite surprising to me. There's only been one prior fMRI study looking at antidepressants that actually implemented an RCT. All the others were either cross-sectional or single-arm designs. So clearly, there's a lot of room to improve our methodological rigor in this area. Then in the area of reproducibility, I think you could argue that there's even more work that needs to be done. There was a paper by Ioannidis' group from Stanford that came out in 2007, and what they did was they looked at reputable cognitive neuroscience journals, and they looked at all of the fMRI studies that were published in those journals. They just then analyzed the effect sizes and the distribution of p-values. And just based on that alone, they concluded that it's very, very probable that at least 50% of those studies, published studies, are false positives. And so that's not even getting into the sampling strategy or the methodology and whether the results are valid. It's just looking at the statistical output. There was also a meta-analysis of fMRI studies in major depression published by Muller in 2017, where they reviewed close to 100 fMRI studies in depression with over 1,000 depressed patients. And anyone know what they found in this? Yeah, it's very simple. They found nothing. So there was sadly no convergence of findings across all of those studies, really pointing to a major problem in reproducibility. Okay, the other issue that I want to talk about is this idea of hypothesis testing versus data-driven research. Because I think that we are acculturated in the scientific community to really privilege hypothesis-driven research over data-driven science. And I think that there's a good reason for that. With data-driven research, there's always a concern of a fishing expedition. Where the investigator has a specific data set and can ask hundreds or thousands of questions of that data and eventually find a statistically significant result. But by and large, that's going to be a product of just chance, randomness, and noise. And I guess what I would argue is that is certainly true, but that is a well-known, entirely explicit, transparent problem. And we now have rigorous statistical techniques to actually address that issue. On the other hand, with hypothesis testing, my worry is that there's a potentially equally pernicious problem, but it's implicit, unaddressed, and untested. And the problem that I'm referring to is confirmation bias, which refers to this tendency that we all have to pay close attention to the findings or data that confirm our results or confirm our hypotheses while discounting or ignoring everything that contradicts our a priori hypotheses. And I thought this was a really, really interesting paper by Joseph Karp at University of Michigan, just highlighting how extreme this problem can be. And what he did in this paper was he took a fMRI data set, and then he looked at all of the different analytic options for processing those data. So within the MRI literature, the investigators have lots of discretion to choose how they're going to normalize the data, how they're going to co-register the data. There's lots of analytic flexibility. And what he essentially found was that when he looked at all those methodological options, all options that are considered, blessed by the field, there were 5,000 different pipelines that he could use to analyze those data. He then ran the data set through all of those 5,000 pipelines and basically found, when he looked across all those results, he found significant activation in the entire brain. So what does that tell you? It tells you that the unscrupulous investigator can basically find results to match any hypothesis that he or she wants. And I want to point out that I'm not trying to say that most or even many investigators are doing that. I do not think that is the case. But I do worry that there is just a human tendency to decide that the methodology that gives us the result that conforms to our hypothesis just happens to be the most rigorous methodology out there. And just in case you think I'm sort of overstating the problem, or if you're saying to yourself, well, I would never do that, other investigators might, there's been some really interesting retrospective studies on Mendel's work in peas. And basically, they've concluded that Mendel was doing exactly that. He was ignoring, or probably eating, the peas that weren't conforming to his hypotheses. What's that? Right, yeah. And I guess, and the point that I'm trying to make is that if the patriarch of genetics can fall into this trap, I think we have to acknowledge that we all can also. The other potential limitation of hypothesis testing is that it risks being myopic. So, in the era of big data, we have incredibly complex, incredibly rich data sets. In the world of imaging, for example, if you restrict yourself to pure hypothesis testing, you risk overlooking vast amounts of data that could be quite meaningful. And my point in bringing this up isn't to say that we should abandon hypothesis testing, absolutely not. It's merely to drive home the point that there are dangers in hypothesis testing, just as there are dangers in data-driven research. Okay. So now I want to talk about some of the recent changes in the way that NIMH is approaching clinical research. As many of you probably know, in 2014, NIMH stopped accepting applications for randomized clinical trials. They'll still accept applications if it's in a specific area that they've requested, but they will no longer accept investigator-initiated studies. And this has obviously had a huge impact on the field and continues to have an impact. They replaced the RCT with an initiative that they initially termed experimental medicine or experimental therapeutics, which then became the R61 grant mechanism. And I want to talk a little bit about that. So in the classic RCT, what we're doing is we're looking at the effects of treatment on our clinical outcomes, clinical improvement. What the R61 mechanism does is it shifts the emphasis towards mechanism. So it dictates that investigators have to first specify the biologic pathway by which treatment yields its therapeutic effect. The investigators then have to empirically demonstrate that their treatment is actually engaging that mechanism or that target. Only after they've done that can they look to see whether there's clinical improvement. So in the example of drug development, an example might be a novel drug. You hypothesize that it hits a certain neural receptor. You first have to show that it does indeed do that, and then later you can test whether hitting that target actually leads to clinical improvement. So there's a couple concerns that I have about this approach, and I want to talk about those. But I first actually want to preface it by saying that my concern isn't globally with the R61 approach. I have absolutely no doubt that there are very well constructed, very well thought out R61 studies, some of them being done here, that will yield important, fruitful information. My concern more is with this being the dominant model for clinical research that NIMH is endorsing. So one of the motivators that they described when they developed this was that they were very concerned, understandably, with RCTs leading to equivocal results. Sorry. And the idea was that clinical trials were being done. At the end of the study, investigators might discover that their intervention was no better than placebo. And what you would hope for there is to conclude this intervention doesn't work, we need to move on to the next one. But that wasn't what was happening. Instead, investigators, understandably, were saying, well, maybe it's not that the treatment doesn't work, maybe we weren't giving it at high enough dose, we weren't giving it with the frequency needed, we weren't giving it for long enough duration. And the only way to solve this problem is to do yet another very, very expensive RCT. And so NIMH wanted to really curtail that, which I think is a quite reasonable goal. But my fear is that that could be wishful thinking. And I want to talk about niacin as a counterexample of this. So as many of you probably know, niacin is a vitamin, but it's been used for years and years in cardiology as a way of treating cardiovascular illness. And there was a clear mechanistic formulation that niacin increases HDL cholesterol, and by increasing HDL cholesterol should lower cardiovascular risk. It was used this way for a number of years, but then interestingly, there were 2 RCTs recently that went beyond just this mechanistic outcome and looked at whether it actually led to clinical improvement. So does niacin actually lower cardiovascular risk? And in 2 large RCTs, they concluded, oops, it actually doesn't lower cardiovascular risk any more than, it doesn't lower it any more than placebo. So if NIMH is correct that this is going to lead to more definitive results, the story should end here. This biological pathway should essentially be ruled out, or at least niacin should be ruled out as a treatment. In fact, that's not what's happened. And the reason it hasn't happened is because biology is really complicated, and there can be more than one mediator. So what cardiologists are now speculating is that the reason niacin doesn't have its effect is because while it does increase HDL, it may also reduce insulin sensitivity, causing hyperglycemia. Hyperglycemia increases risk for cardiovascular diseases. And so these 2 mediators are working at opposing ends. The net effect is no clinical improvement. So now what some cardiologists are speculating is, well, maybe there are certain populations for whom this pathway isn't so salient, patients for whom insulin sensitivity, they're not vulnerable to that. And maybe for those patients, this pathway will take over and niacin could still be an effective treatment. So in other words, despite this mechanistic framework, we're still left with equivocal results. And I point this out not to say that cardiologists should start prescribing niacin again. That's not my point. My point is just that I'm not sure that this mechanistic framework is going to achieve the goal of more definitive findings. Okay. The second major area of concern that I have is that I'm really not convinced that we know enough about the biology of the brain to really have robust targets for our treatments. So in other words, my fear is that we're essentially putting the cart before the horse, targeting certain, or trying to engage certain targets before we really have any confidence that those targets are going to lead to clinical improvement. And I think there's a bit of a guessing game there. So the approach that my lab has taken, as well as others, is to begin with treatments of known efficacy. Treatments where we know that this pathway is robust, where the treatment is going to lead to clinical improvement, and then to work backwards and to find the mechanisms by which they are exerting those effects. That can then feed forward to the R61 mechanism as targets for subsequent treatment development. The critique of this approach, which I think is understandable, is that it's incremental, right? So doing this isn't going to lead to treatment breakthroughs because we're starting with known treatments. And to that, I acknowledge that is correct. It is incremental, but I would say that science tends to be incremental, and that's typically how the field moves forward. Okay, so now I'm going to go over the methodology that we have been using. And it's fairly straightforward, but there's a couple points that I want to highlight. So basically what we're doing is sampling a clinical population. So in the example that I'm going to talk about, patients with depression, doing diagnostic clinical assessments of those patients, and then randomizing them, obtaining a pre-treatment MRI scan, and then randomizing them to either receive active treatment or placebo. After the treatment is over, there's a post-treatment MRI scan. And the strength of this approach, and the reason why I really like it, is that it really allows us to isolate the treatment effects. So if you think about this, in the active treatment arm, the pre versus post-treatment scans should be capturing treatment-induced changes in the brain, or at least MRI indicators of those changes, plus non-specific changes. Our placebo arm should be capturing non-specific changes, and then when we contrast the two, we're isolating treatment effects. And the point that I really want to make here is that this is one of the very, very few methodologies in neuroimaging where we can actually directly talk about causality. We have that level of specificity to say that the treatment is actually causing this brain change, or at least an MRI indicator of that brain change. Okay. So I'm now going to switch to the next part of my talk, which is on our antidepressant studies, where we've been using this methodology to try to identify mechanisms. So the first question to answer is, why study antidepressants? I think that's fairly straightforward in that depression, as you all know, is a very, very common disorder. The lifetime prevalence is about 20%. It's a leading cause of disability worldwide. It's known to disrupt work performance, interpersonal relationships. It's associated with increases in morbidity and mortality. And then probably most importantly, our treatments for depression are clearly inadequate. The STAR-D study has shown that remission rates are only at about 30%, and only about 50% of our patients actually respond to antidepressants. So clearly there's a lot of room for improvement. Okay, so in collaboration with David Hellerstein and the Depression Evaluation Service, we recently completed 2 independent double-blinded placebo-controlled trials of SNRI antidepressants. The first one was a 10-week trial of duloxetine. The second was a 12-week trial of desvenlafaxine, Pristiq. We're looking at adults with persistent depressive disorder. And our MRI data was resting fMRI, which we obtained both before and after treatment. So within our duloxetine study, we started with a total of 65 participants who consented just for the RCT. Of those, 51 consented to do both the RCT with MRI scanning. We obtained usable resting fMRI data pre-treatment in 41 of those participants, and then usable pre- and post-MRI scans in 32 participants. Here's our demographic table, our active treatment arm, our placebo arm. The randomization largely worked, except in sex. There were more females in the duloxetine arm than the placebo arm, and we controlled for that in subsequent analyses. Okay, our desvenlafaxine study, 71 participants consented to the RCT. Of those, 42 consented to both the RCT plus MRI scanning. We got usable data in all 41 of those pre-treatment, and then usable pre- and post-MRI scans in 34 participants. And our demographic table, the randomization was effective here. The first thing that we did was we looked at completers versus those who dropped out or didn't have usable MRI data, and we found that they were comparable on demographics and symptom severity. The next thing that we looked at were the clinical findings, and I'm not going to delve into this into too much detail because we know that these treatments are effective. That's why we chose them for these studies. But just briefly, our active treatment here, duloxetine, placebo, blue is pre-treatment, orange is post-treatment, and you can see that duloxetine is driving down symptom severity to a greater extent than placebo. Same thing in our desvenlafaxine study. Active treatment is driving down Hamilton symptoms to a greater extent than placebo. So both medications were superior to placebo, just as we had expected. And at least in this study, duloxetine seemed to have a larger effect size.
The inclusion criteria for both studies, Karen?
Yeah.
How do you expect the placebo
why is there a difference in the magnitude of the placebo effect? That is a good question, and I think David Hellerstein would probably be better to answer that than I would. Okay.
Random variation. Yeah, so, I mean,
it could be placebo response rates have been increasing. We may be caught in the tide of rising.
We get into that rabbit hole, we'll never get out of it. Melanie can probably say that the difference between the placebo response rates and the two are probably not statistically significantly different.
Okay. So our approach to the MRI data. So we took a data-driven whole brain approach, looking at whole brain connectomics. And the way that we did that was for every individual voxel in the brain, we looked at the neural activity over time, and we correlated the activity in every individual voxel with all of the other voxels in the brain. So in other words, every voxel becomes populated with about 100,000 correlation coefficients times 100,000 voxels. So a massive correlation matrix of 100,000 by 100,000. We then use principal component analysis to reduce the dimensionality of those data. And this is all a methodology that Susan Whitfield Gabrielli worked out at MIT called multivoxel pattern analysis. Okay, so our results. So this is what we found, and this slide can be a little dizzying at first, so I want to walk you through it and highlight 2 points. So the regions in red that you see are regions that are showing connectivity change over time, but these are interaction effects. So at this point, we don't know if the change is driven by active treatment or if it's driven by placebo, and I'll get to that later. The other point that's interesting is that we don't see the usual suspects here. So we're not seeing connectivity change in amygdala, hippocampus, prefrontal cortex, regions that are typically implicated in mood disorders. Instead, what struck us is that we were seeing connectivity change in periaqueductal gray, mid-cingulate, some supplementary motor area, posterior cingulate. And these are all regions that have been implicated in a neural circuit related to the experience of physical pain. And this circuit is perhaps best described by Tor Wager in his 2013 New England Journal of Medicine paper. And the regions in orange here are regions that become increasingly active when people experience physical pain relative to a control condition. So we next wanted to sort of, by visual inspection, we noticed parallels, but we wanted to try to confirm that with data. So we took 2 approaches to that. The first thing that we did was we compared the anatomical overlap between the brain map that we came up with, so over here, with multiple well-described neural networks. So the overlap between the pain network, the default mode network, executive control network, several very well-described neural networks. And what we found was that the overlap was greatest with the pain network. The second approach that we used was using an online platform called Neurosynth, which is a really interesting data-driven approach. And what you do here is you can upload your brain imaging findings. So we uploaded this map onto Neurosynth. And then Neurosynth has a large database of fMRI studies. And using a blind algorithm, it matches the regions that you're seeing in your brain map with the terms that have been used in literature to describe those regions. And so the terms that came out most readily from our data were pain, painful, and sensory motor. Sensory motor cortex is part of the pain network. So with those findings at hand, that led us to formulate the hypothesis that perhaps SNRI medications are impacting the pain network, and perhaps that's explaining some of their treatment effects. So we next wanted to directly test that hypothesis. And to do this, we began with the regions that in the pain network that were defined by Tor-Wager. And so these brain maps show the 16 nodes that he defined in that network. Hold on one second, Jeff. We didn't want to take our own data to prevent the problem of double dipping. We wanted to start with the pain network defined elsewhere. We then used a graph theory metric called network density, which basically looks at the connectivity across all of these 16 nodes. So it generates a 16 by 16 matrix, calculating the correlation across all those nodes, and it comes up with the mean connection strength across that full matrix. So it basically is a way of crunching down data from a large matrix into one single number. We first looked at treatment effects in our duloxetine study, and I'll walk you through this. So here's our active treatment arm, our placebo. On the vertical axis is the pain network density, or the connection strength across that network. Blue is pre-treatment, red is post-treatment. And what you'll see here is that duloxetine is driving down connectivity in that network, whereas placebo is having a non-significant effect. Oh, okay. Thank you. Okay. We then did the same analysis with our second study, the desvenlafaxine study. And again, here we're seeing. Okay. People hear me okay? Yeah. Okay. So in our desvenlafaxine study, we found the same results, that desvenlafaxine was driving down pain network connectivity where there was a non-significant change within our placebo arm. We then pooled the data across both studies, and not surprisingly found the same effect. Active treatment has this impact on pain network connectivity, no effect in the placebo arm. One other aside that I like to mention is that the reliability of our measurements really do matter. And so by having this placebo arm with pre and post treatment, we were actually able to do sort of a poor man's test-retest reliability. And we weren't expecting the pain network to show perfect stability because patients in the placebo arm are getting some intervention. But nonetheless, we found an interclass correlation of 0.6, which indicates not perfect reliability, but pretty darn good reliability, particularly for neuroimaging data. Okay. The next thing that we looked at were clinical correlates. And again, I want to emphasize the point that this was a data-driven approach. So we didn't go in with the hypothesis that we were going to be hitting the pain network, and patients weren't recruited for having symptoms of physical pain. Depression and pain are often very comorbid, so it was present there, but it wasn't an inclusion criteria. And we also didn't have detailed assessments of physical pain for that reason. But we did collect data from the symptom checklist 90. And within that self-report measure, 4 items ask specifically about the experience of physical pain. So what we did was we tested whether there was a relationship between change in the pain network and improvement in pain symptoms. And that is indeed what we found. So here is the change in the pain network density. As you go up, that indicates a bigger drop in pain density. And as you move to the right here, that's a larger improvement in pain symptoms. And interestingly, what we found is a significant correlation in our active treatment arm, but not in our placebo arm. The second thing that we looked at was whether there was a relationship with depressive symptoms. And here we had the Hamilton 24 item. And again, found similar effects where the larger the reduction in pain network density, the greater the improvement in Hamilton symptoms. We found that in our duloxetine study. We then replicated that in our desvenlafaxine study with a relationship in the active treatment arm and a non-significant relationship in our placebo arm. And again, when you combine the 2 studies together. Okay. The last analysis that we were working with on this study and I should preface this that we're still sort of finalizing this analysis and working with Melanie Wall and her group on this, is we wanted to test whether the effect of the pain network, the effect of SNRIs on the pain network was what was actually driving symptom improvement. And so to do that, we used path analysis, and we did find a significant mediation effect. So what this is showing is that the impact of treatment on network density was accounting for the impact of treatment on symptom improvement. It was the change in pain network explained about 12.5% of the total clinical effect of SNRI medications. So what that tells us is that clearly the pain network is not the sole player in explaining how SNRIs work, but it seems like it's an important player in a potentially important target for new treatments. Okay, so to summarize, there's clearly a complicated relationship between pain and depression. The two are highly comorbid. Pain in and of itself can predict the subsequent development of depression, and depression in and of itself can exacerbate pain, potentially by lowering the pain threshold. We also know that SNRI medications have an indication for neuropathic pain in addition to their antidepressant indication. And what our data are suggesting is that SNRIs decrease pain network connectivity, and that this accounts for at least some of their clinical impact. So now I want to talk a little bit about where we'd like to go with this, this area of research. And I think one of the most important things would be to have a finer time scale, a more granular time scale. So for example, having more than 2 MRI time points would allow us to really tease apart the mediation hypothesis in a much more robust way. But then also equally important, if we had a much finer time scale on the trajectory of depressive symptoms as well as the trajectory of pain symptoms, what that would allow us to do is essentially tease apart the direction of causality. So we could ask whether it's actually the impact, whether changes within the pain network are what's driving MDD symptom improvement, or conversely, is it improvement in depressive symptoms that's actually driving the change in the pain network. With the data that we currently have, we can't actually tease that direction apart. The other area that I think is really interesting and potentially important is depression is a diverse disorder. And so the question is, are there patients with depression for whom the pain network plays a much larger role in their condition? And would those patients be better treated with an SNRI medication versus other available antidepressants? And then the last area, and this is the one that we're still sort of scratching our heads over, is whether there's a way to move beyond just MRI substrates and actually develop cellular targets. So knowing that the pain network is important in antidepressants is interesting and helpful, but if you really want to develop a new compound, a new drug, you need much more granular information. You need information at the level of a cellular target. And because my lab is really focused on children and developmental populations, we wanted a methodology where that could be applied to kids. PET is an obvious answer, but you can't do PET imaging in children. Okay. So I'm now going to move on to the last area of my talk. And I guess I want to preface this by saying that this is very much a work in progress and not yet a fully baked idea. So I appreciate any thoughts or feedback on this. But again, the idea is, how can we move from a circuit-based understanding to either a cellular or a molecular understanding? And so as we were sort of scratching our heads trying to think about this, an observation that Juk Cha in my lab made was looking at how oncology is using diffusion tensor imaging. And for anyone who doesn't know, if you ever want to know where sort of the cutting edge biological research is happening, oncology is always a great place to start. I just want to back up and say something about DTI, diffusion imaging. So in psychiatry, we typically think of DTI as an approach to measure something about white matter. But in fact, all DTI is measuring is the diffusion of water molecules. And water molecules, yes, they diffuse through white matter, but they also diffuse through gray matter and any other tissue in the body. So there's no reason to restrict it just to white matter. So one of the interesting and exciting things that's happening in oncology is that they're using diffusion imaging as an indicator of early treatment response. And the idea is when you have a tumor and that tumor is hit by an anti-neoplastic agent, there's all sorts of tissue remodeling that goes on. And it looks like DTI is a very, very sensitive indicator of those early remodeling that happens. There's been multiple papers in the oncology literature now on this topic. So to delve into that a little bit more, when a tumor is hit by an anti-neoplastic agent, lots of different cellular changes can occur. There can be apoptosis, necrosis, cellular swelling, fibrosis sets in. All of those changes lead to change in diffusion parameters. The major drawback of this approach is specificity. So it's highly sensitive to these changes, but figuring out which one of these changes is actually driving the DTI effect is really, really unclear. The big advantage that they have in oncology that we don't have in psychiatry is biopsy. So they can get these diffusion parameters, they can then go in and grab some of the tissue, look at it under a microscope, and actually match the histology with the diffusion parameters that they're seeing and try to figure out which one of these biological processes is driving their MRI effect. Clearly, we don't have that option in psychiatry. But the way that we've been approaching this is that psychotropic agents cause lots of cellular changes within the brain. Dendritic arborization, neurogenesis, glial morphology, all of those changes can be picked up on DTI. That's pretty well established now. So we can index those changes with diffusion imaging. The problem is, how do we get to specificity? How do we figure out what's actually driving those diffusion changes? And that's a big puzzle, and I'm going to give you the best approach that we've come up with, although, again, open to other ideas on this. So the approach that we're taking is trying to move, instead of going from bench to bedside, we're actually trying to go from bedside back to bench. And what I mean by that is that we're starting with our human RCT, obtaining pre and post RCT diffusion scans, and relating that to clinical outcomes, just as I showed you before with the resting fMRI data. But in parallel with that, we're also doing the exact same experiment in a rodent. So a rodent gets randomized to psychostimulant versus placebo, gets a pre and post diffusion scan. And our hope is that if we can find analogous changes in the human brain with what we're seeing in the rodent brain, we can then use the rodent brain as our object for biopsy and actually drill down and look at the cellular and molecular effects. So it's our way of trying to get around not being able to get human tissue, but to get tissue nonetheless. And one of the points that I want to make about this, and this, I have lots of collaborators who are epidemiologists, and one of the things that I love about working with epidemiologists is their constant emphasis on external validity. And in any kind of animal study, again, I have great respect for animal researchers, but one of the struggles is maintaining external validity. So the findings that we see in animals, will those translate up into humans? It's a well-known problem. Our hope is that by having these two experiments done in parallel, we can actually maximize the external validity of our studies. So this is a study that's still ongoing, but we've completed the human arm of it, the children. we did an RCT of Vyvanse versus placebo in kids with ADHD. It was a 12-week trial with pre and post MRI scanning. Here's our demographic table. The randomization was effective in matching active treatment with placebo on demographics and symptom severity. We then focused on diffusion parameters within the striatum. And we did that for two reasons. One is because prior studies that have looked at psychostimulants, albeit cross-sectional or single arm, have repeatedly pointed to the striatum as the central region where stimulants have their effect. But the other reason is because we wanted to maintain that translational approach. We wanted to be able to see the same effects in the rodent. The striatum is a region that we can readily map out in the human, but we can also readily map out in a rodent brain. We can't do that in, say, the prefrontal cortex. Or it's much, much more difficult. So what we found was, here's our placebo arm, here's our Vyvanse arm. There was no change pre versus post in FA, fractional anisotropy, in the placebo arm, but Vyvanse was driving up FA in our active treatment arm. FA refers to how freely water molecules can diffuse. So increasing FA means you're actually reducing the ability of water to diffuse. We then looked at the relationship with symptom severity. And again, what we found within the striatum, the increase in FA correlated with the improvement in ADHD symptoms. The next step that we're trying to take, and we haven't quite completed this yet, is to recapitulate these findings in our rodents. We've started that study, and we have actually, in collaboration with Christoph Kellendong's lab, we've looked at structural imaging, but we haven't gotten to the diffusion imaging yet. But within our structural imaging, what we found is that Vyvanse was increasing left striatal volumes to a greater extent than placebo, and that was specific to the striatum. All the other subcortical regions that we looked at, there was a non-significant difference. And so the next big question that we have is, do stimulants also drive up FA in the striatum? And that's still to be determined. Okay, so conclusions. So the first thing that I hope that I've shown you is that I think we need to get rid of this idea that data-driven science is really second-class research. I think that arguably there's advantages and disadvantages to both approaches. The second point is that I think studies of existing known treatments really can help us understand mechanisms, and they can provide targets for new interventions, and MRI can be a powerful technology for identifying that. The next point is that we're excited about these pain network findings as really a new potential target for treatment development, and also with implications for precision medicine. Again, this idea, can we identify patients where the pain network is playing a larger role in their disorder? And the last point, and again, this is one that we're still sort of struggling with, is how do you make MRI findings more actionable? So one approach that we've taken is trying to couple human and small rodent imaging, but clearly there's lots of other answers to this question. So there's lots of people I want to acknowledge. This is my lab. The people in the lab who were most involved in the studies that I mentioned are listed here: Yun Wang, Juk Cha, Dominique Bazonsky. And then I really want to thank all of my collaborators. I have one of the real joys of working at this institution is having sort of the breadth and the depth of the faculty here. And it's a real pleasure to be able to work with so many people in the department. Here I've just listed the people who were directly involved in these studies, but I want to give a big thank you to all of my collaborators. So.
Well, Jonathan, you certainly gave a really stimulating and ambitious talk and addressed a number of areas that are, in themselves, hugely complicated and important areas, whether it's, treatment development, RCTs, placebo response, biomarker development, and, how you try and, develop a clear mechanistic understanding, even at the cellular level, of how treatment effects are. So obviously, you're not daunted by scientific challenges. So basically, did you want to say something? Okay, I'll try not to go on too long. Basically, if I understand correctly, whether it's because of the NIH getting frustrated with the lack of clear results and progress with therapeutics research, or otherwise, and the rising placebo response rates, you're trying to develop something that goes beyond symptomatic or clinical subjective reported assessment, and that's about. So the NIMH, which I have a lot of things critical to say about, has tried to do things along those lines, like EMBARK. It's also has a program which is basically based on a fast-fail paradigm of treatment development. So you're familiar with that? Mm-hmm. So a fast-fail model is that don't bother with animal models predicting the likelihood of a treatment being effective, because the animal models are not highly predictive. So go right to humans, but before you can go to humans, you have to know that you've got a treatment, whether it's an antidepressant treatment, antipsychotic, an anxiolytic, psychostimulant, that engages the target in an adequate way to be expected to produce this hypothetical therapeutic effect. And so the first thing is you have your theoretical neurobiologic target, dopamine, serotonin, protein, benzodiazepine receptor, monoamine oxidase, whatever, and you want to have a measure to show that your putative medication is acting at that. And PET is the best because it's a molecular measure with a biomarker. I mean, with a radioligand that can actually measure it. MRI is more removed, but you've got more variety and it's less invasive. So if you then convince yourself you've got a measure of target engagement and you show that giving doses that are safe and tolerable produces a measure, it stimulates hemodynamic activity on fMRI, or it produces an increase in a resonance peak on MRS for choline or creatine or GLX peak, or DTI, whatever the measure would be, then, okay, you can say your treatment is acting on it, and you would go into patients, and you would administer it in patients, and if it worked, then you claim victory. If it didn't work, you could say, well, either the drug doesn't work or the target doesn't work, because we know that the drug engages the target. Okay, so that's basically what you're trying to do. No?
No, I don't think so.
Okay.
What I'm trying to do is figure out what's an appropriate target for that type of study.
So, okay, the target for the study, meaning a measure of the treatment effect.
No, so the mediator that you define, I would argue that we don't have a good sense of what those mediators should be. So what type of target should your novel intervention actually be engaging, and using existing treatments to help define what those targets could be?
Okay. I'm not sure I understand it. Anybody else have a better understanding of what Jonathan's saying? Any of our imagers?
I can, well.
Claire, Catherine, you want to step in?
I was just going to say that you identified a really not yet identified area of the brain that is not, although I have a footnote on that mm-hmm. with a late Ed Smith paper, mm-hmm. but that has not yet been brought into the depression work.
Right.
So the pain network. So that's a new area of target, and it opens up alternative treatments.
Yeah, so yeah, thank you. So an example, Jeff, would be you have a you now think, because of this work, that the pain network will lead to symptom improvement in patients who are depressed. Can you develop a novel intervention that actually will engage that target? And that was a target that prior to this work wasn't so clear.
Right, right. So you identified this pain network post hoc, based on I mean, it was you declared your intentions up front, so you're not doing any kind of retro post hoc, massaging of the data, but you looked at your areas of change, hemodynamic change, and you saw that the nodes that were changing were those that corresponded to what Torwager had identified as reflecting a pain network, and thought that that might be a proxy for therapeutic antidepressant effects.
Yeah.
To measure instead of what might be more traditional measures. And that's good. And then you did a prospective study which validated that, right? And that's the way biomarkers should be validated. So then, is that now an accepted measure in the depression field?
What, the pain network? Is it an accepted measure? The network density? No, it shouldn't be. I mean, it's the first report of this, and also it's not. I should state again that it's only explaining about 12.5% of the total impact of SNRIs on treatment response. So, I think it's reasonable to hypothesize that for some patients that percent is probably larger, and the pain network is playing a larger role. But I don't think that, we certainly don't know that yet.
Okay. Yeah, I mean, I'm not trying to give you a hard time, and the only reason I'm being impolite is because you're one of us, and also because of the fact that you're really engaged in a very important and technically challenging area of research, and as people who work in sort of the group that I sort of live in, it just bugs the hell out of me how people publish stuff that never is replicated, that turns out to be spurious, and are not methodologically rigorous. And the fact that they get a pass by editors of journals, as well as in some cases study sections, is just unfortunate. So I think the rigor, the emphasis on rigor that you're placing is entirely warranted. It's not for the faint of heart. And I admire what you're doing. I'm just trying to kick the tires a bit to make sure that you've got a firm foundation. Catherine, did you want to add something else?
Yes, please. Thank you. Really great talk.
And Goro in the back.
And thanks so much for challenging us the way you did. So 2 quick thoughts. So working, of course, with TOR was the late Ed Smith, and they did a study, I presume it was Columbia undergrads, and they had a group of folks who'd just gone through breakups, romantic breakups, and a group who hadn't. I'm not sure if you know this paper.
No, I don't.
And actually, so the romantic breakup group, the loss, had TOR's pain activity, pain network activated.
Right.
So it might be really interesting when you think about precision medicine, and we know that loss plays a role in depression.
Right.
Is that maybe a subgroup?
Yeah.
And it's more relevant for that group.
Yeah.
And then also just in terms of the experimental therapeutics, I think it's really important to remember it's not just biological targets, that the mediators can be cognitions and behaviors.
Yeah.
So just to keep it broad.
Thank you for bringing that up. I want to address both those points. So I'll take the second point first. You're absolutely right. What NIMH says explicitly is that it doesn't have to just be biological measures. Any measure is acceptable. But I think implicit in developing that approach was the idea of PET imaging. And if you look at the funded R61 studies, I believe this is true, that they're not all, but MRI and PET is certainly widely represented. And I mean, I do MRI research, so I'm okay with that part, but on the PET side, what that means is that the dominant approach for clinical research in NIMH is off limits for children. And as a result, there's very, very, very few R61 involving kids. And that's worrisome. The other part of your point, I think, is very well taken. I feel a bit silly, like an armchair philosopher saying this, but we have different terms for pain and depression, and those labels make it sound like they're two distinct categories, but certainly there's a lot of overlap. And when someone articulates pain, what they mean by that could overlap a lot with when another person refers to as depression. And I think that's actually why having an MRI measure of that network could be so powerful as opposed to just a self-report measure.
Hi, Jonathan. Thanks for that talk. And I had a comment. I just wanted to say I really like this approach because it's the humility in saying that we don't fully understand the mechanisms. So let's not go out of our way to make up some story about the mechanism and then go and prove it. Just use what tools we have to find potential mechanisms. I really like that approach. And I think it's one of the main ways we should be looking forward, is because we do have treatments that work, and let's try and understand how they work first before going and designing totally novel targets.
Thank you.
And so the one question I had then about the depression findings is you kind of concentrated on the pain network aspect there. I was wondering what other networks, because it wasn't fully only pain that I could see in that distribution of hits there.
Yeah.
And did that increase the variance explained if you started looking at other networks that were also hitting that, and so that you could see multiple networks that were involved and maybe how they were interacting in the future?
Yeah, thank you. That's a great question and a great point. Yeah, the findings that we had from our whole brain approach overlapped somewhat with the pain network, but the overlap wasn't, you're absolutely right, it wasn't 100%, indicating that other regions and potentially other networks are involved. And that's also consistent with our mediation results, where we only saw the pain network explaining, a portion of the clinical impact. One of the areas where we've started looking at that is on the placebo arm. So I showed you that, somewhat surprisingly, the relationship between symptom improvement and connectivity change was found in the active treatment arm, but not in the placebo arm. So we've started to explore what's actually mediating the placebo effect, and we're still sort of in the process of teasing that apart, but I'll tell you briefly that it looks like more frontoparietal networks are involved in that.
Myrna.
Well, now we know what you do in your spare time. That was wonderful.
Thanks.
Very elegant.
Thank you.
I was just trying to think, these studies are so expensive and time-consuming. And what is existing that you might be able to test out, at least counterfactual? I wonder in the EMBARC, where you don't have an SNRI, but you do have data on depression and pain, and the downside of the EMBARC is you don't have it at the end of treatment. You don't have the MRI, but you do have it before the person got on medication and then after a week of medication. And I'm wondering whether any of that data could be used to test out some of these findings using a different drug, where you would hypothesize you wouldn't find the same with pain.
Yep. Yeah, I think that's a great point, and something that we're very much interested in doing. And I think what we could look at is whether sort of getting at the time scale and having a more granular time scale that I was talking about. So it's possible that you see a change in pain network density early on in the course of treatment. So after 1 week of treatment, even though you don't see improvement in depressive symptoms until until much later. And so that's definitely an approach that would be great to look at with the EMBARC study.
And there's 287 subjects, and it's all here and available.
Yep.
Ralph.
Yeah, I have a concern with some of the language and the evolution of the sense of target. I mean, target was first defined when they had salvarsan or syphilis. You're dealing with a bacteria and you have a target. Now, from what we're saying, there are circuits involved, and the pain circuit is a double circuit. There's an inhibitory circuit, and there's a descending and ascending circuit. So pain circuits are extremely complex. Mm-hmm. And the complexity is not only neuroanatomically, but it's also meaningful. In other words, the meaning of pain differs from person to person. So if you break your leg when you're a postman you're in bad trouble. Your work is out. If you get shot in the Army on the battlefield, the pain saves your life because the helicopter will get you out of there. So the meaning of pain is extremely complex. So just to say that it's connected to the pain circuit, you're dealing with extraordinarily complex circuit in terms of, as I say, both pathways up to the brain.
Yep.
So maybe we've got to talk more circuitry. And then when you make a leap from, let's say, not using the term target, but pathway, to get to an ultra microscopic level, that seems to me contradictory. How can we get to mitochondria or intracellular stuff when we don't even know the circuitry?
Right.
And the circuitry is going to be extremely complex, even among twins, with identical twins, having a trillion number. The circuitry and the meaning of pain, like a breakup that Catherine mentioned. The meaning of a breakup to somebody who's graduating high school is different than a breakup in a marriage. So these are much more complex than simply looking for a target. It seems a contradiction, huge contradiction, philosophically and practically.
Yeah, I really appreciate your point, and I think target gives the sense of much greater specificity than we really have, and I like your idea of talking about pathways and circuits rather than target. In that transition from pathway to actual cellular target is very complicated and very difficult. We're making our best attempt by using the animal models, but it's by no means there's a lot of potential problems with that approach as well.
David.
Yeah, hi, Jonathan. Terrific talk, and really great to see some results from our studies, which have been going on for a very long time. And I just wanted to add some additional comments to what Jonathan said. We did 2 studies that were both pharma-funded, and this was initially with Brad Peterson as the MRI collaborator when he was still here, and we did multimodal MRI imaging in the context of the RCTs, and so we have a huge pool of data that is yet to be analyzed. Ravi Bansal did a paper in molecular psychiatry last year that from this data set, from the duloxetine data set, looking at anatomical findings, and Myrna, you and I should talk about it. It's very actually different from what was found in the high-risk study, but interesting about chronicity of depression and compensatory mechanisms. There's also a paper in submission, again, at Molecular Psychiatry for MR spectroscopy with Ravi Bansal as first author as well, which is also has the capability of looking at mechanism. And Jonathan had done a paper, I think it was 3 or 4 years ago, looking at the default mode network in the duloxetine paper.
Is there a question?
Sample. Yeah, so I'm just saying it's a complex study with a really interesting and powerful method. And I would say one thing is that the power of imaging plus a clinical trial is sort of 1 + 1 = 100 or 1,000, because you can get findings that are far beyond what you can get from either alone. So I guess, Jonathan, would there be ways that you could look at some of the other modalities of imaging that we have that could help to confirm some of these findings? So for instance, we have DTI for both of those studies.
Mm-hmm. Yeah, I mean, certainly you can look at connectivity from other perspectives using other MRI modalities, diffusion being one of them. And in my lab, we've done some of that where we've tried to use both functional connectivity and structural connectivity, diffusion measurements, to look at the connectivity within a circuit. It is, it's a tricky process because they are, even though we refer to them both as connectivity, they're measuring very different things. So, functional connectivity is measuring how synchronized 2 gray matter regions are, whereas diffusion imaging is measuring a property of, in that context, a property of white matter. And so 2 regions can be synchronized without actually having a white matter pathway connecting them through a 3rd cortical node. So it's one of those areas where if you have convergence of findings, that's great. But if they're not convergent, it's hard to really interpret that.
All right, well, I'm going to make a couple of ad hominem comments that I don't want to be too much of a curmudgeon or a wet blanket, but I really think we're in order. Just it's not meant to be, badass, but really to try and save people a lot of trouble in getting to a point that people who have been in the field for a long time have gotten to, which is, and you started out alluding to when you're talking about, the lack of replicable results, the studies that came up with no significant findings. What is the incentive for academics to do research? I mean, obviously everybody wants to find the truth and help people, but thinking in more mundane terms, it's to get promoted, to get paid, to get grants, to get things published. So nobody should be under the illusion that there's not a lot of other motives that crop into what ultimately results in the scientific literature or in grant applications. Secondly, if you take all of the publications on modalities that are so-called potential biomarkers, whether it's imaging or analytes in serum or CSF or EEG or PET or anything else, and you try to distill it down into what was replicated, found to be true over time, and then even beyond that, what's permeated clinical practice, you'd come up with, I don't know, something of the subatomic level probably. And the claims of things, so David, I'm going to pick on you a little bit. You rattled off a whole bunch of publications. If you were to sort of put a tracer on those as to where they go in the literature and whether they hold up or not and whether they actually prove to be meaningful, the question is sort of, what is that going to be? Now, the reason I'm saying that is because all areas of medicine are really stuck with this. I mean, cholesterol for heart disease, glucose for ST depression, EEG, spike wave activity. There are validated biomarkers, but there's not a lot. It's not easy. CNS disease using imaging, apart from MS and maybe amyloid, radioligand, doesn't have them either, and those have much more tractable diseases than we're dealing with. And psychiatry is riddled historically with false claims. The most egregious ones were in the early days, antedated everybody here, the pink spot, the mauve spot, taraxine. These are analytes in serum, urine, CSF that turned out to be metabolites of coffee, because people on inpatient units drink a lot of coffee, or psychotropic medications that get metabolized. And then probably the most, it wasn't because of any malevolent intent. It was just claiming victory before it was justified. But it was probably the DST, dexamethasone suppression test. In the 1980s, psychiatry thought it had the first diagnostic test, for depression, and a huge ballyhoo. But it's kind of faded into history because of non-specificity. And then imaging. What has panned out with imaging? Aspirationally, that's, I think, probably the best bet. But it's a long way. And if the idea is to get things into publications and show how smart you are, or even to get grants funded, that's good to a degree. But the reality is that this is very tough stuff. It's technologically dependent. And in the long haul, somebody's research productivity is or should be, really evaluated on really the its veracity in terms of replication and it providing another piece of empirical evidence that will further a line of investigation into various disease areas. So I just want to throw that as a warning. Question I wanted to ask, though, and I see Randy's got, we'll come to you in a second, but I want Jay to think about in the meantime. How do you get from the, you saw Jeff Lichtman's talk when he was here a couple of years ago, the anatomist from Harvard? Well, look at it on YouTube. He does this amazing talk where he'll blow up like a cubic, I don't know if it's a cubic nanometer of tissue and shows the amount of different cellular elements in it, and then sort of tries to relate that of how you interpret MRI and fMRI. And it's like, looking at the universe versus looking at something under a microscope. So it's daunting. But I was going to say, since you aspirationally have said, how do we get to like a measure of some cellular element or process that is reflective, I was going to ask Jay if he sees that as something that's plausible or not. But in the meantime, Randy.
I'm going to give you 30 seconds to think about that. That was a really, really wonderful talk, and it's so impressive.
His or mine?
Both of yours. I should have started there. You're right.
I'm just
but
kidding.
I thought, it just made me think of a lot of different things, and one of the things that because you're doing so much, and I know you're doing this area too, is that there's this kind of really interesting relationship between prediction and normalization. And of course today you focused more on normalization. And I guess my question is twofold, but really relating. So if this kind of pain sensory network, which has been, as Catherine alluded to, implicated in a lot of functional imaging work with namely Eisenberger, focusing on the insula, the interior, and so on and so forth. I guess my question is, as a normalization target, is there reason to believe that effect that we're seeing is specific to SNRIs? And you did, in full disclosure, you didn't note this as a limitation of the pre-post design. Or would we expect, and this is kind of where I'm leaning without any actual evidence, that might just be a generic change that we would see irrespective of whether it's a pharmacological manipulation or even a therapeutic manipulation, because we know that one's pain changes as a function of their response to treatment. And so there's that question, but the related question also is, to what extent are these mechanisms that we see going to relate to what we could use as prediction, which ultimately would always be more pragmatic?
Mm-hmm. So those are both really good questions. So as far as the specificity, I partially agree with you that from these data, we can't say if this effect is specific to SNRIs or would be generalizable to other antidepressants. But what we can say, and so where I partially disagree with you, is that we did have a placebo arm, right? So we know that there is some degree of specificity. It's not just a non-specific effect of being in a clinical trial or change over time.
But those folks who had the placebo didn't experience the same level of depression symptom change, right?
Correct.
Right. So I mean, I'm saying, if we could even look in other data sets that are out there to see if in a psychotherapeutic trial that had a pre and post resting state, to see if to what extent it's specific to the SSNRI versus just this is what you see when symptoms change.
Right. Right.
That you could use.
Now we could use the EMBARC. Right. Yeah. I mean, I think there's reasons to suspect that it may be specific to SNRIs because they do have a pain indication where SSRIs don't. But it's a good question, and it's certainly something. It's a empirical question that could be looked at. As far as the prediction part goes, I mean, I think EMBARC is sort of the ideal data set and was really designed to try to address that question. And I know you and I were talking about this a little bit before. Juk Cha in my lab has really kind of spearheaded this work trying to look at the EMBARC data and develop predictors of treatment response using different machine learning algorithms. And one of the things that's really, really difficult about that is it's like either you hit a grand slam and you find the predictor or you got nothing. Because if you come up with a model and it predicts accuracy at, say, 60%, that's not clinically useful. What you'd want to do is to be able to pull out and figure out how is the machine actually learning that. And that step, it turns out, is incredibly difficult and complicated. So when you have sort of a prediction that's better than chance but not clinically usable, it's not so clear what you can do with that information.
But EMBARC provides a nice cautionary tale of that as well, because what they're seeing is, looking at theta within the dorsal ACC, is that it's a generic predictor, but not a specific predictor. And I think that's where I'm worried that we're kind of circling a little bit, that we're finding generic predictors.
Although in EMBARC, the dorsal ACC finding that I think you're talking about correlated with symptom change in Hamilton. In our data, the change in pain network does not correlate with symptom change. So it suggests that perhaps there's a bit more specificity, but your point is still well taken.
Jonathan, was there a follow-up to that? No, because I wanted Jay to talk, but if you're going to ask, you're going to comment on this, go ahead. If not, it's a different thing, then wait.
Respond that there were people who did improve with placebo, and the overall change in Hamilton wasn't as big in the placebo group, particularly in the desbenlafaxine study. There were a significant number of placebo responders, and yet no change in the pain network. Jonathan could look at just the responders. I don't think you did, but he could look at just the responders. But I'm willing to bet from those graphs that they don't change the pain network at all, whereas the active responders would. So I think that answers your non-specific, or could answer the non-specific.
Jay, do you want to take a crack at this?
Yeah, I got bonus time to think. But we don't have much time, so I won't engage in a soliloquy here. But no, I don't think I'm as pessimistic as you are, Jeff. I mean, I know that sometimes we feel like we can be spinning our wheels in psychiatric research, that the things we think are going to be, big breakthroughs really don't end up holding up. But I don't know. I mean, I feel like we made a lot of progress in the genetics of these disorders. I feel like the same thing that I felt when I came into psychiatry, which was so tempting to me, was weighing neurology versus psychiatry, is that the neurologist could put, would take a couple tomes or more to contain all of their knowledge about mechanism and anatomy and other things, but their therapeutics could be put in a pamphlet. Whereas psychiatry, we don't have that therapeutic nihilism. We actually do have effective treatments, and that's really why I enjoyed Jonathan's approach. I think sometimes we're so enamored with trying to find the next greatest, newest thing, something better than what we have, when we really don't even understand how it is that the treatments we do have, which are, arguably effective, they could be better, we don't understand how they work. So it's definitely a place where I feel like sometimes we get so enamored with, oh, nobody wants to fund anything having to do with serotonin anymore. Everything's about glutamate. But we still don't understand how SSRIs or SNRIs work, much less the tricyclics. So I think that, science has always been built on a foundation of shifting sands, right? And psychiatry's not alone in that. We've probably been more susceptible than others, but I'm actually relatively optimistic. And I think Jonathan's approach is a valid one. I think we tend to underestimate the value in understanding how these older techniques work, or these older medications. We don't even understand how ECT works, right?
On that note of optimism, which I fully endorse, thank you, Jonathan.
Thank you.